Dr. Jcrc Mutuluza. I'm the Executive Director of the Joint Clinical Research Center. And on behalf of the Jcrc, I would like to welcome all viewers, students, maybe some faculty from Western University to this virtual meeting or training. We would have loved to have you here physically like we've done in the past, but because of the COVID era, this is not possible. But we hope that next year you'll be able to join us to explore what Jcrc has to offer. The Jcrc was established in 1991 to address the national HIV/AIDS crisis. So this was a scientific intervention in the epidemic, which was at the highest in the world at that time. So this was set up as a strategic venture at the time to maximize the scanty resources between the Ministry of Health, which provides the policy guidance, Makerere College of Health Sciences, which did provide and still provides the human resource and researchers we work with, and the Ministry of Defense Department of Health, which provided the initial infrastructure, and we continue to work with them. The vision of the Jcrc is to be a vibrant, self-sustaining center of excellence in medical research, training, and healthcare services. The objectives at the time were to carry out research on HIV/AIDS and related conditions, but this has been expanded to include other emerging health conditions of interest. We provide quality HIV/AIDS care and treatment, but also other diseases that are emerging or are prevalent in our population. And we provide facilities and logistical support for training activities that support research, care, and treatment programs. This is just an overview of the different buildings at our campus, which is the headquarters of the Jcrc based in Kampala. However, Jcrc extends beyond the headquarters. We have regional centers of excellence across the country. Those in red are the ones that were set up originally, and those in green are centers that we have set up because of the PEPFAR work we are doing in the area of HIV/AIDS in those regions. And these centers all have laboratories that support quality assurance and lab capacity for the public sector. They provide training opportunities, and they also conduct research. These are the different sites across the country. And since the inception of the institution, there have been several achievements. I will just mention a few of them. The Joint Clinical Research Center pioneered use of antiretroviral drugs in Africa and has started the largest number of patients on ART, maybe we can say in the world. The center also pioneered HIV vaccine trials in Africa, both preventive and therapeutic. We have been part of over 100 trials, and some of these have been landmark trials that have shaped policies and guidelines in Africa and beyond. One of them is called the START study, and this study informed the WHO to change when patients can start antiretroviral drugs. We have established state-of-the-art laboratories for HIV basic and clinical research, vaccine development, monitoring of antiretroviral therapy, and these labs are now CAP certified. We have developed national network model for service delivery and provided initial national HIV/AIDS services, including viral load. We introduced viral load in 1996, and also early infant diagnosis in all the regional centers that I already showed you. Jcrc has a wide research agenda, and very briefly, We conduct a lot of clinical trials for HIV and other infections. We are involved in vaccine studies. We are involved in research on TB, which is very common also among HIV patients. We have research projects on sickle cell disease, cardiovascular disease, malaria. We do research in virology, immunology, social and behavioral studies, and also epidemiological studies and pharmacokinetic studies that have led to the approval of especially pediatric treatment in developing countries and across the world. We have excelled in research, and in 2017 we were recognized as the best research center in the country by the government. And also in 2018 we were part of the team recognized for outstanding research in 2018 by the European Union. And this was because of work we did under the Jcrc trials. These were looking at children with HIV in Africa, pharmacokinetics and adherence to simple antiretroviral therapy. And we've gone from conducting Jcrc 1 trial, now we are doing Jcrc 4 trial. And about a month ago, some of the drugs we worked on, including dolutegravir for pediatrics, has been now certified by the FDA of the US. Within all this work, one of our main area of focus is training. And the goal of our training is to expand national capacity to address the public health and scientific challenges of the evolving HIV and TB epidemic in Uganda through training, clinical and field research. We build capacity in the areas of clinical, operational and health services research on TB, HIV and other health conditions. These are some of the programs that we've been involved in, supported by the National Institutes of Health, WHO, and also PEPFAR funding. One of the biggest was this is the Fogarty International Center AIDS Institutional Training Program, supported by Fogarty. And this was a collaboration with Case Western Reserve University. We've also had collaboration and continue to work with the Centers for AIDS Research, which is called CIFA. And we had an International Clinical, Operational and Health Services Research Training Award for TB and AIDS for 10 years, which was a partnership with Case Western Reserve University, University of Georgia, and this was coordinated by the Jcrc and other institutions we worked with in the country, included Mbarara University and Kampala City Council. As part of this, we also developed a master's program in the School of Public Health in Health Services Research, and this program is still ongoing. We are part of the AIDS Clinical Trials Group, which was set up by the NIH. This, in 2006, developed an international clinical trials program to go outside of the US in an effort to facilitate the transfer of expertise to conduct quality clinical and translational research in resource-limited settings. The Jcrc has been part of this network, working with Case Western Reserve University. We have conducted over 20 clinical trials under this network, and Jcrc has been among the top recruiting sites for several studies. Currently, we have under this network 5 clinical trials, and others are in the pipeline. To do all this work, we have a staff of 279, including both technical and non-technical team. They are very well trained and experienced in research, and we collaborate with researchers from Makerere, other universities in the country, but also internationally with universities and the research institutions both in the US and in Europe. And we look forward to working more and collaborating more with institutions from Canada. The Jcrc, as already mentioned, has the state-of-the-art laboratories that are certified by the College of American Pathologists, and this is the highest level of standard any lab in the world can get. However, we have to work very hard to sustain that level of quality. We have specialized labs, and some of these were set up with the Case Western. In particular, Eric was one, or when he was still in Case, who supported us to set up a drug resistance lab in 1999. This is now WHO and CAP certified. It's supporting both the national HIV program and regional HIV/AIDS treatment programs. We have a TB lab, which is one of the best in the country. We have immunology laboratories that have helped us to understand TB and HIV interactions and how TB treatment can be improved. These labs are one of the biggest labs in the region with a menu of over 50 tests. This is just a pictorial of the TB labs. Also, to support our research, our community networks, we have developed community network systems in all areas where we operate from. We have a community advisory board which links the center with the community to support research. And we also have a band composed of youth living positively with HIV who help us to create HIV awareness, fight stigma, and encourage treatment through music and drama in the communities. So with that overview, I think these are some of the training and internship opportunities that we have here at the Jcrc. We have a big agenda in research. We currently have 19 research projects that are running, and 15 of them are in the pipeline to start in the course of the year. We take care for over 14,000 individuals, and we have created a database on how these patients are doing, which has been in existence for over 15 years. So there is a lot of opportunity for people, especially who are in statistics, to come and work together to analyze, do secondary data analysis on the database that we have. We have state-of-the-art laboratories. I've already talked about them, and also these provide an opportunity for people, especially in the lab sciences, to come and work with us. We have community-based project for TB case identification and linkage to treatment for those that may be interested in community work. As already shown on the map of Uganda, we have PEPFAR-funded programs in the north and southwest of the country, where there are a lot of opportunities and a lot of questions and on how we can improve practices in the field. We also have the Jcrc regional centers of excellence where students could be placed. These are spread out across the country. And one other area, of course, is innovations. We are working with different groups that have made innovations that we are evaluating. Right now, we've been working with a group from Wisconsin. We are evaluating a simple and cheap assay for COVID testing. We are already in the process of doing that. We've also been evaluating a very simple diagnostic assay for TB using urine. So if there are any innovations that you have at Western University, these can be developed jointly and also evaluated in our communities. I will now talk briefly about the infrastructure developments that we have at the center. We have, through the support of NIH, now have an apheresis machine. This is the first of its kind in the country, and it is supporting us in our research on HIV cure agenda, but we've also used it for red blood cell exchange for sicklers and also other infections where this is recommended. We have expanded our work to put a standalone TB clinic because TB is very common, and also we are doing a lot of research in TB. We have a repository of over 50 freezers with samples that have been stored since 1991, and also this repository is an opportunity for people who want to answer certain questions. We have a cardiac laboratory that has been developed in partnership with a professor from Case Western Reserve University, and this has helped us in research projects, but also supported the clinic in investigations and care. We have a dental clinic which was also supported by a team from Case Western Reserve University, and this one also provides care for our patients. What are the future priorities of the Jcrc? We are looking at injectable long-acting antiretroviral drugs, and we have 2 studies in the pipeline. These are going to start in the first quarter of next year, and one of them will be for adults and then for adolescents. The one for the adults will be coordinated for Africa by the Jcrc, and the study will take place in Uganda, Kenya, and South Africa. We are looking at projects for the cure for hepatitis B and C as core infections or standalone infections. We are looking at novel drugs, treatment shortening for TB and also HIV, new drugs. We are looking at multiplex sequencing for when we are doing HIV drug resistance to simultaneously screen for other viral infections and emerging infections. We are also diversifying to look at non-communicable diseases, especially cardiovascular disease. We are very keen and working in the area of HIV cure agenda and HIV reservoirs, and also transplantation medicine, where we want to pioneer stem cell transplant in the region. And for stem cell research and therapy, a few patients who have money can travel to India, South Africa, or maybe even the US to get the benefits of bone marrow transplant. And so Jcrc, in collaboration with other departments in the country and with support from other international established institutions, has the goal of setting up a center of excellence for stem cell transplant research and therapy in Uganda and the region. We also hope to be working in the space of gene therapy for HIV and also sickle cell disease. We will work on different diseases in a phased manner, and the first one we are looking at, of course, is HIV. where we have expertise, and then also sickle cell disease. But there are many other diseases that could benefit from stem cell research. And when we look at the HIV cure agenda, I think there are challenges, of course, but use of functional CD40 cells that are resistant to infection by genetic modification of the CCR5 HIV co-receptor provide a platform to achieve or to address these challenges. And we now have in the world 2 patients that have been cured using that method of transplant. This is a schematic of what we will be doing, also collaborating with Case Western Reserve University. So we've made the achievements we have so far because of partnerships, and moving forward, even the areas where we want to go, we are still looking for partnerships and collaborations in order to achieve that work.
As the Finance and Administration Department or Directorates that incorporates different heads of departments, including finance, including ICT, including procurement, including stores and warehouse management, including transport, and all the back office operations. There are quite a number of training opportunities that you can learn from the Directorate, including issues like taking care of medical supplies. How do you ensure that supplies that are related to research and medical care are taken care of in the right condition that would meet the criteria of different protocols? How do you ensure that the logistics around, how do you bring in logistics that require medical supplies, drugs that meet the standard are done in the right way? In finance, there are quite a number of opportunities that you can also take advantage of, including learning from how do operations regarding project management, project finance related issues can be done. Also, how do you combine the issues regarding finance in a medical and research institution? There are quite a number of details that you need to learn, you would want to learn from. There are also issues regarding how do you ensure that the systems are in place that are fit or comply with the different requirements of the donors. We've also had a number of systems that have been strengthened over time, including financial related systems that combines reporting and standard reporting, and combines also management of donor-funded programs, of donor-funded grants, and a number of our donors across the world have come and tested the systems, and they've found them to be sound. So we do want to come and learn from such kind of systems. For our students across the world, we want to assure you that when you come, you're going to have a great opportunity to learn from all these back office operations. We guarantee you a duty of care that when you come, for us, the student care is paramount and key, and it's a priority for us as an administration. And we shall ensure that you receive a well-coordinated program that assures duty of care. We will have very good and sound ICT platforms that will enable you to, it's a top-notch, really, ICT platform that coordinates all operations at the center, and that will ensure that you have uninterrupted internet connectivity that will allow you to exchange and communicate across the world with your parents, with your fellow students, and also to download education materials. That is something that we want to assure you that you'll have when you come over. We also want to assure our students that we can be able to coordinate and ensure that you have accommodation and logistics around your travel. When you come over, you'll be able to get a modest accommodation that is quite affordable, and to ensure that you're comfortable when you're here, and your stay will be really something that you'll ever talk about. In case you require letters of support for your travel, that is something we shall do, and ensure that we coordinate with the ministries required, the embassies required to have letters of support, that your travel is easy, and all the administrative and logistics around your travel will be quite very good. We wish to welcome you to the Jcrc, the Center of Excellency, and I want to give you a comfortable and life experiencing placement that we'll talk about. They'll be able to even call other people to come and have a taste of this placement.
The clinical directorate, I can say, is the directorate with the largest number of staff at Jcrc. It comprises of several units. It comprises of the adult outpatient clinic. There is also a pediatric outpatient clinic. Where we are seated right now is the private clinic. And then we also have a 15-bed inpatient facility. So it is in this clinic and the ward where we actually interact with patients, through consultations and offering treatment. There are other units in the directorate that actually support these big clinics. For example, we have a radiology unit that offers X-ray, digital X-rays, offers ultrasound services. We also have a pharmacy. The pharmacy, we have a big general pharmacy that mainly serves the adult outpatient and the pediatric clinic. The private clinic also has a private pharmacy that's sort of a subsidiary of the main pharmacy. The inpatient facility does not have a pharmacy yet, but manages its own cache of drugs. In addition to the pharmacy, we also have smaller units, like we have a dental clinic. It's actually quite a modern dental unit. It has the latest equipment. It's currently manned by a dental officer. We also have a cardiology unit. It's also manned by a registered nurse. The cardiology unit, basically, apart from doing consultations, it also has the capacity to run ECGs, electrocardiograms, and echocardiography. The most recent addition to the clinical directorate as a static unit has been what is called the apheresis unit. The apheresis unit is a procedure we use for removing harmful substances or cells from the body and replacing them with other fluids or substances. For example, we use it very commonly in red blood cell exchange for sickle cell disease patients. So, for example, sickle cell disease patients come to the unit, and sickle cells are removed from their body. Their red blood cells that are sickled are removed from their body, and they are replaced with fresh blood from Nakasero, from the blood bank, from the National Blood Bank. This is the only unit. It's usually the aim of that procedure, for example, for sickle cell, is that it reduces the percentage of sickled cells in the blood. So it doesn't cure sickle cell, but it reduces complications. And it is currently the only apheresis. Our apheresis unit is the only unit in the country.
So here at Jcrc, we have championed the treatment and management of HIV for a very long time. And it's a very big opportunity for you to come through and learn and see how this is managed. We have so many other ailments that we take care of. We take care of dental problems, we take care of heart problems as well, and we also have a TB unit, and we take care of a full range. The menu is big in terms of the tropical diseases that we mainly manage. So we'll start from the reception and see how the flow goes, and you'll be able to see firsthand how we manage our patients and how we take care of them for a very long time, because it's a chronic illness and therefore they become part of us at the end of the day. One of the longest patients that we've had is now making over 30 years. So here is our reception area, and all the patients that we take care of, we have over 15,000 patients that we take care of. This is one of the biggest clinics in Uganda. So every patient is registered, all right? And if you're new, again, you also get registered so that you have a cumulative number, all right? So this clinic, like you may have had, started way back in 1991, okay? So we've had patients that we followed up for all those years, and therefore we had a cumulative number over time. A card just looks like this, you know? There are no names, you can't know anyone. So for purposes of stigma management, there are no names. And we have, of course, to keep confidentiality. So it's one of our training. You know, you keep confidentiality of your patients. So we know the date of birth, we know their gender, we know when they started the ART, and inside here, just an appointment. Okay. So we have, when the patient comes through, they see this lady here. I think I can say your name, Florence. You can come and see. She's called Florence Chintu, and she's our desk person. She's the first person that interacts with all the patients, so she's very, very busy, all right? And she has to sort out who is new, who is old. Luckily, the new ones she is able to see because they don't have cards, all right? She's able to take her their details, and then take them to the next step, most especially the counselors, who now register them, get their details, their biography. After getting the information, then they are able to get out a number. The number which I showed you in the card, I say a number, that cumulative number, okay? So if the last patient was, say, 430, the next one will be 431, all right? Now, having got all those details, the number is generated and the card is issued. And we'll get to know, are they coming in for blood checks, blood draws? Are they sick that they need to see a doctor? Or are they just for drug pickups? So it's easy. She's the one to sort it out. And the first stage is to do their triaging. Triaging is basically to take their vitals and everything. And the officer in charge at this station of the loop is none other than Erimo Peter. Once they're distributed to the various rooms in the doctor's places where we are going to go next, we are able to interact with them and do a what we call a clinical assessment. And that's where the gist of the matter is, the technical bits go in. We have, this is an example of the doctor's office. We have over 4 doctors who are able to assess these patients when they come through. They do their history taking, they do the physical examination, and they note everything onto the computer. Every patient has a page where we write those clinical monitoring notes. Now, the diagnoses are then written out into what we call ICEA. It's a platform where we interact as doctors to show what sort of diagnoses the patients have had, and they're able to help the next doctor who will see this patient follow up.
Because it is entry to the treatment, we do HIV testing and counseling for both adult and babies and children, and those who test positive, we put them on care, and we handle clients
with psychosocial issues, because as you know, like HIV is one of the cause of trauma. People have depression. Because of that, some stop taking drugs, they give up in life. So when it happens like that, we counsel them and then they come back to life. So we do a lot of that. Someone can say like, I'm tired of taking these drugs, if I die, I die. So you have to tell a lot, counsel them to change the negative attitude to positive attitude, and life continues. So we have also clients who have poor adherence to treatment. So as you know, like the successful of treatment, you have to have and take the by road. So when we find those ones, we give them what we call intensive adherence counseling. So it means you have to go dig in their life style, or sometimes even you visit them at their homes and help them to take the drugs correctly. Then we also go to the communities, because like we can't be and we are not in the communities where parents live. So sometimes we get program where we go and test the community around. We test them for HIV. And we start on them on drugs the same day. So everything is done in the community. So afterwards they come here and continue from where they started from. So we've been having students who come to learn the skills, the theory. They learn theory in the universities, then they do practical from here. We have students from, we normally host students from Makerere University, Chambogo University, Mukono University, and yeah, those famous universities who have their social work and counseling faculties. So they come and work with us. They learn how to practice counseling in a real sense, not in a theory. Our patients come to the clinic, they start to the reception where they are registered. The people you see at the reception are peer supporters. They help us to identify adolescents with problems, because it's easier for them to interact with their peers compared to us. So when they identify the adolescents with issues, they are sent to the counselor. So it's the starting point. They get registered, then they take a cup of tea, then they are entertained. So we move to the actual reception area. This is where the vitals are taken. We have two groups of patients. We have the general patients and we have patients who participate in research. This is where the different coordinators sit, the coordinators for the different trials. It's a big room, and that's where the files are. The doctors in the clinic where the sick patients are referred, and also trial patients. This is our phlebotomy area where the children come in for the blood draws. Both the general patients and those who are participating on trials. We also participate in trials that involve pharmacokinetic studies, so everything is handled here.
Quality improvements is broad, it is big, but one of our major roles or core values is to ensure quality within the systems, as well as managing of our clients at Jcrc. This team works with a broad number of people, and it cuts across right from the gate to the extreme end through to administration. But majorly within the clinic activities, we help identify areas of improvement, that we work closely with the people that are in charge of certain departments to ensure that we have smooth running of the clinic. We support the clinic in that if there are any issues or related complaints or something from the clients, we address the issues and we resolve them to ensure continuity of their treatment. We also manage the patients that have been lost to follow. We follow them up, give them calls to find out what is happening, how they are doing, and how best we can get them back to the clinic. And that is Eric Ziwa, one of the people I work with on our team, and he's currently following up some of the patients that we think are stranded somewhere and would require services, and part of what we have been doing is delivering drugs to wherever they are for as long as they are within our catchment area of Kampala Wakiso. So that's an exercise that has been happening during the COVID period, and we hope to continue to help our clients wherever they are.
So this is our apheresis unit. This is the waiting area. Relatives gather here as they are working on the patient within the unit. It is the Spectria Optia apheresis system. And this unit can do multiple things. It can do red blood cell exchange, it can do plasma exchange, it can do collections for platelets and plasma. Actually, we are even planning to use it in COVID-19 treatment. So basically we collect plasma from patients who have ever suffered from COVID-19, and we use the antibodies in that plasma for therapeutic purposes.
Radiology department will have a digital X-ray system and also have a high definition portable ultrasound unit. So, but the trainees have vast opportunities because of the conditions we see here. Like in X-ray, they will be exposed to the latest technology in X-ray department, whereby you're exposed to lung conditions, bone conditions, soft tissue conditions, and with high technology that defines everything very well. So they will also learn how to interpret, because we have a senior consultant radiologist who is at our disposal for consultations and other things, but mostly conditions to do with chest, heart-related, vesicular-related. You will be able to get vast knowledge in that. This is a workstation where we control radiation from, we enter patient data from, we see exposure from, we choose the projections from, and we're able to post-process from here and then print from here digital copies if we want. We can also send them digitally to whoever we want it to send to. And then of course this is our exposure console. So this is a panel where we calculate which dose to give you, which projection will I be taking, and which part will I focus on. All are manipulated from this console. Then from the exposure console, workstation, we go to now examination room. In the examination room, this is mainly an X-ray that is digitized it has what we call flat panel detectors. So this is majorly X-ray diagnostic, and we have what we call, as I told you, high technology. This is a flat panel detector that receives X-ray radiation, converts it into light energy that is taken. I told it is wireless, so it is picked up by the Wi-Fi system there, and then able to demonstrate it or portray it on the monitor. So it is radiation controlled. So everything is regulated very well.
This is our dental unit. We had a chance of training students last year from Canada, and we do almost all dental procedures around here. So when you're going to sterilize instruments, we always first wash them from inside, like I'm going to show you. Then we come here and sterilize them. We always operate it from here, like you see. We have our functional dental chair. So this dental chair works and it functions very well. We operate it from here. That's where all the movements are made from here. Here we have the intraoral dental camera, which is working, as you see. This one helps us to take pictures from inside the mouth for the client to easily see, so that whatever we are accessing, the patient is also aware. Here we have our dental X-ray. So the X-ray also works, and we take our X-rays from here in case of need, which is very necessary in dental procedures. This is our X-ray. Then all the materials that are needed, we have different kinds of materials. The filling materials, we all have all of them around here. We have the fuginine, we have calcium hydroxide, each and everything that is needed for filling teeth. They are basically kept here. We do procedures like scaling and polishing, what most people call cleaning of teeth. We do filling, dental conservation, most people call it filling. We do root canal treatment, whereby we remove the nerves and the teeth stay in the mouth. We do extractions if necessary.
It was opened in the year 2013. And mainly it was for echo and then ECG, which we do to cardiac patients. Mostly we are dealing with rheumatic heart disease. We went to school screening them, and then now when those who are confirmed with the disease, we give them prophylaxis of injections. In this clinic, I have a doctor, but she stays in a pediatric clinic because I only call her when I have a patient. And most of the patients brought here mainly it's for my work, and then there's another radiographer who does ultrasound. So the patient, the students we get here, they are interested in the patients we are seeing here. The last student was from Canada, and she participated a lot in the research I was doing because I was doing research concerning the heart, whereby we do vital signs here. She would help me do vital signs, taking weight, blood pressure. Then we would do exercises outside. She would participate in making sure that the participants are doing the exercises, and she counts, she sees them through. And then we would also take them to Zambia for CT scan. And she would also go with us to Zambia to see the procedures done there. Here in this clinic, we also do or ECG. They also learn how to fix these electrodes on the patients, and they know how to at least do the procedure of doing ECG on patients. And we also have the ultrasound machine. When they're here, they also watch the ultrasound being done, and there they are also taught, because when they're there in the ultrasound, like echo or ultrasound, they can see the organs, internal organs. This year, actually, my study patients are not coming for their visits, so we are calling them to let them know that we are staying with them, we are following them up. We shall be calling them next year. At the moment, they are still analyzing the examinations done last year, and then they are also looking for funding for the next stages. So they should not think we have forgotten them. We are still with them. Also to find out how they are, if they are doing well, any problems, so that at least we are aware of what is happening. And they know they are still with us in the research.
Patients come to healthcare facilities. At the back of their mind, they expect to go with medicine. If they don't go with the medicine, even if they have seen the best clinicians, the best caregivers, they don't feel they have been properly served. And therefore that put pharmacy at the center of the activities that we do here. And also, as we know, ART, that is antiretroviral therapy, is treatment for life. So if the commodities or if these medicines are not available, we would ourselves as healthcare providers be interfering with the treatment that the patients duly deserve. So as pharmacy, our core activities are, one, to ensure that we have the ARV commodities that the patients need. Good enough, we have guidelines which stipulates which drugs to use, so selection of the commodities is no longer a challenge because we just follow what's in the guideline. And the Uganda ART treatment and prevention guideline is adopted from the WHO guideline. Yeah, so as Jcrc pharmacy, we work within that scope of commodities. But as I've also mentioned, we have research activities, and almost all the research activities ongoing at Jcrc have drug component. So again, the pharmacy team play a very key role in research. Our key activities under the research is one of them is to advise the researchers on the regulations regarding drug-related studies. What are the requirements for submission of the protocol, what is called clinical trial application, to the different authorities. The most important one, or the critical one, is the National Drug Authority. So we advise the researchers on the requirements for the different activities that will be undertaken under the research. We manage the investigational medicinal products, which are the IMPs. Those are the drugs which are used in the different studies. Most of these research activities that we do are collaborative, meaning we work with partners outside Uganda, but also others within Uganda. Yeah, so where we work with partners outside Uganda, some of the drugs are either not yet even registered in Uganda for clinical use. So those ones, we need to advise the researchers on the steps to take so that we obtain all the regulatory requirements and documentation in place before the study actually begins. Once you have imported the study drugs, they have to be stored under stipulated conditions. Those conditions are stipulated by the manufacturers of the different IMPs. So we ensure those conditions are in place. The controlled temperatures, where refrigeration is required, we have refrigeration. But also we know power outages in Africa is a common thing. But for us here in Jcrc, we have standby generators which automatically start within 3 seconds. So that means there is literally no gap. That ensures all the drugs, whether they are refrigerated or under controlled room temperature, are kept within the stipulated conditions. So this is our pediatric pharmacy, where we handle prescription from the pediatric department for children and adolescents. So the drugs come from the pharmacy store, where we go and see. The pharmacist here manages the stocks, counsels the carers on how to take the treatment and how to keep the drugs properly at home, and also to bring the returns at the next visit, because for children, like we already said, the treatment is tailored according to the body weight and the age. This is our meeting area. We have regular meetings for the different activities that we do here. Yes.
Thank you.
As you can see, this is control entry. Whoever enters here has to be either the pharmacy staff or access granted to him or her by the pharmacy staff, because it is fingerprint, and I'm the one who allocated to the pharmacy staff. So this is the main store for the pharmacy. We make requisition for drugs from the stores, from the main warehouse, once a month, because we know the regimen that these patients are on. We know the visits are scheduled in terms of appointment, so we can know in advance how many patients are expected within a month, within a week, within a day. So based on that, we project the requirement for the month and make a requisition. So we do, to manage the stock and do accountability, we do physical count once a month, and we reconcile what we have counted vis-a-vis what the card says. If there is any discrepancy, that is investigated and resolved. This is a quarantine area for drugs that have expired. So these are waiting for audit to come and verify, and then we move them from here for destruction.
Thank you.
So access is also restricted. Yes, so this is the main dispensing area for the pharmacy. Drugs are replenished in this section from the stores on a daily basis. Like I already said, we know the average number of patients coming on a daily basis, which I've already mentioned, 200. So we make a transfer from our main store to refill this area, and then we dispense to the patient according to the prescriptions that come. For cotrimoxazole, which is still being given as a prophylaxis to the majority of the patients, we do prepackage the Septrin. The prescriptions come online. We have a clinic, integrated clinic enterprise application, which is the database that we use for the clinical care of patients. So on it, the prescribers take the medical record and do the lab request, and eventually make a prescription. The prescription automatically comes to pharmacists.
It is a two-story building, and it has done a lot of both research and clinical work in Uganda and outside Uganda. And it is currently accredited by the College of American Pathologists, and this is the largest lab in East Africa, accredited with the over 60 tests, to simplify, over 60. And we maintain all those tests on external quality assurance, in brackets EQA, and all of these materials are supplied by College of American Pathologists. So you pay membership fee, you pay for the EQA materials, and then you pay for inspection fees. And all that summed together, you are nearing 100 million per year. So we manage to maintain it because of the studies we get from the international bodies, international sponsors or collaborators, and we get a smaller fee out of that, and we are able to maintain the accreditation. We have a biorepository, which I'll also walk you there, with over 40 freezers, that's minus 80 freezers, where we store our samples. And these samples are for future storage and future tests, and others are for shipping to the respective collaborators who work with for further tests which we cannot do here. Right now, as COVID pandemic is raging on, we are developing our own testing tool. Before we were struggling with the drug antibiotic resistance in the population, and before we finish the antimicrobial resistance, COVID has come in. But are we not going to say now we are dealing with COVID and look abuse of antibiotics in the pharmacies? No, we say we have to go ahead. So we participate in this by doing some research. We have a colleague who wrote a project and got some little money. So we want to be involved in looking at antimicrobial resistance, both in humans, animals, and environment. So the samples will be collected from these different communities, and we see how this drug antimicrobial resistance is transmitted and what mitigation measures can we have. So those are some of the plans we are having. And then HIV drug testing, yes, we are doing. We are using the Sanger method, but now we are transitioning to new generation sequencing machine. And why? Because this one, the throughput is higher and better because technology changes. So all of this put together is our future plans. And we still call upon the researchers for support, people who can fund us. We work as collaborators and train students.
This lab is a research lab and clinical lab, and we mainly focus on HIV drug resistance as research and for patient care. So as a clinical lab, we are part of the national program for HIV treatment, in that we monitor all the patients who are on antiretroviral drugs by doing a drug resistance test for them. And also being at Jcrc, we also take care of the patients who are on treatment, because with treatment there is need for monitoring. So we monitor these patients to see that they are responding well to treatment, and then for that we do a viral load. That's the first line of monitoring, and those that are not suppressing, because in the first year you have like 10% of patients not suppressing, in the second year about 20%, then we have to ask why aren't they suppressing. With that background, we do a drug resistance testing, and basically what a drug resistance testing is that we are looking at, normally when patients are on treatment, the virus tries to run away from the drug, to escape drug recognition. And by doing that, it causes some mutations within key areas where the drugs bind. And when it causes mutations there, then the virus is not able, the drug is not able to recognize where to bind. And so then the virus has the liberty to replicate. So by doing a drug resistance test, we are able to ascertain which patients are taking their drugs well and which patients are, even if they are not taking their drugs well, they are not adherent. So by doing a drug resistance test, we get patient samples, we target the virus within the patient sample, and we amplify the region that is targeted by the drugs the patient is on. And like I mentioned, that those regions, they are usually mutations that show that the virus is escaping. So by doing that drug resistance test, we sequence that region that we have targeted, then we look for those particular mutations that will confer resistance or escape of that virus from the drug. The gold standard we use is the Sanger sequencing. It has been around for many years, but it has a limit of detection, which is about 20%. So anything below 20% you cannot detect. So that is the limitation of that method, but with current technology, we see that now there are more methods that are newer, and you're able to detect these mutations as they come in. So you can detect mutations as low as 1%, and that is using the next generation sequencing. This sequencing is called deep sequencing, whereby the virus is sequenced at great depth, and you're able to detect very, very low frequencies of this virus. So this is good for patients who are starting treatment, because if you find these viruses at low frequencies, then you cannot start a patient on a drug that the patient has low frequency mutations on. And also for patients who are already on treatment, the doctors can decide that, well, if this mutation is coming up, most likely within a short time, it will be up to another percentage, and it will cause cross-resistance. So it helps us to detect mutations early and then change treatment for the patient so that the patients can thrive well on their medications and just lead a normal life. I'm a case alumni, and I was under the supervision of Dr. Eric Arts for my PhD at Case Western Reserve University. I was in the lab for 5 years with him, and then when I started also work here at the Jcrc, he was my boss then for quite a number of years. And also it's important to note that Dr. Eric Arts is the one who started the HIV drug resistance laboratory at the Jcrc, and all the drug resistance assays were developed with the collaborations at Case Western, and we also continue to collaborate with him at Western University in Ontario.
So in the hematology section, we do the routine hematology tests like full blood count, blood smears, but we also do blood transfusion medicine. The National Blood Bank provides us with blood units for transfusion. We receive the blood and record all the details in these files that we have hidden. These are our documents for the blood transfusion. We receive the files from the blood from the National Blood Bank. We record them, then we keep them in our blood banks, as I've shown you, with our recording temperatures. We are very specific about this. So our entire process from blood grouping to antibody detection to cross-match is done in a CAP accredited method. We don't, most places use trial methods, but for us to use test tubes to do our entire procedures, and it's CAP accredited. In addition to that, we support our sickle cell clinic. They bring requests as usual, as we have seen there. They bring requests from patients needing sickle cell apheresis. Then we cross-match the blood group. We antibody screen, then we cross-match, then we give them to the ward.
And in our clinical chemistry lab, we have two sets of equipment. One does the routine chemistries, and then we have the other machine doing immunoassays and the cardiac markers. This is the Architect Abbott analyzer. It does the immunoassays, and by immunoassays, I mean tests like toxoplasma, cytomegalovirus, hepatitis B serology. We also do P24 HIV combo, and we also do cardiac markers on this machine. And then on the other hand, we have the Cobas Integra. This one does the routine chemistries, the liver function, the renal function, the lipid profiles, and all drug toxicities are done on this analyzer.
So this is the, as I mentioned, this is the virology lab. So this is David Eram, that's Dennis Odochi, and at the moment they are preparing to do the validation of the diagnostic procedure we are developing in the lab for diagnosing Ebola.
This is microbiology. We have a range of tests we do. We shall begin the simplest tests we do, the serological tests. Also screen for syphilis using I mentioned HIV. Also syphilis as an STD in HIV using the RPR test and anti-treponemal antibody test to confirm it. Now this way, we have this BACTEC machine which does blood culture. This helps to rule out sepsemia in HIV patients. This is an HIV center. We also have, we do bacteriology using this robust machine called the BD Phoenix 100. This is a big machine, analyzes 100 specimen. 100 specimen within 8 hours. We shall also be looking at the environment, being a One Health approach, which affects the human beings, the plants, the animals, and the shared environment they live in. For the environment bit, we shall look at the vegetables around and sample them to get samples to look at the drugs that we shall isolate and look at the patterns of the resistance. We shall also look at the water bodies around the farms, the poultry farms around Kampala, which is a big challenge in the country and globally. This research will be beginning the next, I think, 2 months. We also do lots of parasitology, stool parasitology. We isolate parasites in stool in human beings, more so in the HIV setting here. This is a fume hood where we do our isolation and staining of the protozoa isolated from the stool. This is a technique that helps you not to miss out even the hidden parasite that you would have missed using other methods of concentration and direct wet preparation. We also have other tests we do, which include the mycology. We look at the yeasts. We identify yeast in HIV patients, also cryptococcal nymphomans, and also several species of Candida, which isolate and differentiate them to guide the clinicians. Still, all these things we isolate, we use the BD Phoenix to help us identify the organisms and also the drugs of choice to use. And this shall guide the clinicians which drugs are sensitive, which are resistant, which goes back to the antimicrobial resistance, which has become a challenge in the country because people are buying drugs over the counter, not knowing if it will be effective and doing self-treatment. We have CLED, we have blood agar, we have the Mueller-Hinton of the sensitivity manual, we have SS. This helps us to isolate Shigella and Salmonella from the stool samples. We also have SDA media, which is essential in the isolation of the different types of yeasts we get from our patients.
Jcrc storage room, biorepository house, where all samples are stored for all research we take we are managing. So please, let's come in. It's under key and lock. Nobody is supposed to access it unless you have rights from the lab. So this is a biorepository lab where we keep all samples that we receive from our research protocols. We have over 15 freezers, and these freezers contain different samples for long storage. We have a system that manages monitoring temperatures for these samples. It is automatic 24/7. We receive messages on our phones, we receive messages on our emails in case the freezer is out of range of temperatures. We're also planning to install a solar system that will be able to back up the power system. We're also planning to buy a machine that will be producing dry ice for our shipments. So we have keys that nobody should come in and try to open, because we always have safety of these. So we have keys that we use to open. And when you look at all, they are almost full. These are samples that we've been storing for the different protocols. We also get students that come in and do trainings in here, how to manage samples, how to store them, how safe they are for long storage, for other future uses. Yeah. So we give them names to identify them from other freezers. They have different names. There is Josephine there, we have this and there, we have Sisi as our ED, that is her freezer named after
her. Firstly, why we do community programs is that we are aware of global shortages in health workers. We are aware of the poor distribution, especially for low developed countries like ours. The distribution of health facilities is so poor, and there are performance gaps, and the health workforce is so thin. So such gaps are actually normally met by structures on the ground. Structures emerge on the ground to fill these gaps through the private sector or private not-for-profit. These come in to meet these gaps, and community-based organizations which are embedded in the community present a very good approach to be able to meet local needs at a domestic and community level. And if you consider such ambitious targets like universal health coverage, which everybody is targeting globally, by the time we get there, SDG number 3, of good health and well-being, by the time we arrive there, we'd have done a lot of individualization of this healthcare. How are these designed? There are several structures and several designs for community programs. So many of them based on the context and based on the intervention, based on the kind of people and the targets that you are looking at. So we design these programs based on how we want to reach the communities, the need that is there, and how we want to create a sustainable outcome, not just basically doing an intervention and getting out. What are the benefits of running community programs? This is outstandingly, it has become a hot potato, because community programs actually bring the point home to the community, bring it to a domesticated community level, where you in fact have a solution that the last man understands, and that last man's change, or that last man's change in behavior about their health, will bring about an improvement and a change, in the direction which you want, depending on what you are targeting.
I'll just briefly talk about what we do in the centers, joint clinical research centers outside Kampala, because you have already been informed about what goes on in our main campus here in Kampala. We have other centers in Mbarara in western Uganda. That's about 4 hours from Kampala by road. And we have other centers in Fort Portal, which is again about another 4 hours, and another center in Gulu, which is 5 hours, and another center in Lira in northern Uganda, which is also about 4 hours by road from Kampala. And in those, what we here call up-country sites, some of the centers are involved in clinical research, and also we have one particular center which is not involved in clinical research. That's the one in the northeast Uganda, which at the moment we are running a community work. It's targeting comprehensive HIV services, HIV and TB services, but it's based in the community. Our work there is mainly to increase access to HIV care services and prevention, and also to increase the uptake of those services. And among the opportunistic infections we deal with, particularly there, is TB.
Under community, we are normally looking out for key populations. Those key populations include men who have sex with men, commercial sex workers, injectable drug users, and prisoners. Then we also look out for priority populations. These include fisher folks, adolescent girls and young women. They also include truck drivers, and as well as men who are about 40 years of age. So some of the models we are using in the community, we are using the model of village health teams as well as CLVs. The village health teams are the people we find in the village, in the community, who help us access the key population that we want, the kind of people that we are looking for. We don't normally do an outreach just like that to target the whole population. We normally go out looking out for specifically certain group of people who are highly at risk with this HIV virus. So when we get into the villages, we normally look out for the mothers, like for commercial sex workers. We work with the mothers of those groups. They call them their mothers because they're the ones who take care of them when they're doing their business. So we look out for those mothers. We identify the hot spots in the community, which kind of hotspot is there. So we look out for those hot spots. We penetrate through them, through their peers. Those peers help us identify those other colleagues of theirs in the community. So when we do that, we then get to the right people we are targeting to test. The kind of outreach we do at that time is called a moonlight. It's named moonlight because we target people at night, and then the moon is the one that lights us as we do our work. However, we have torches, we have other things to help us out as we carry out the activity, but they named it moonlight. So we go out to meet them at that time when they are working. That's why we call it a moonlight. So we find them at their workplaces, and then we offer to test them, free HIV counseling and testing.
So we have a robust key population network and peer leaders to ensure that we identify positives. We work through their networks, and more people are identified easily because of that approach. We also are implementing pediatric and adolescent case finding, and we have vetting strategies that we've implemented to ensure we retain patients on care, because that is the biggest challenge with most of the facilities in the country. You can identify positive, but retaining them on treatment is not easy. So most of the The approaches we use is to use root cause analysis, finding out why they don't come back to the facility. But also we have a team that is actively calling these patients to make sure that they keep appointments and find out why they are not keeping them. Here we are also implementing the differentiated service delivery model at the facility, and this includes month drug scripting, which may include also 6 months prescription, where the patients are given drugs to last for a long time to avoid them moving back and forth to the clinic, and also to improve identification and ARV coverage of men and adolescent groups. With the support of the CDC and IDI, Jcrc is also currently a national referral center for HIV drug resistance, and we carry out this training, which is specialized, and not many facilities in the country are able to have this kind of infrastructure, but Jcrc has it.
Department at Jcrc started at the inception of Jcrc in 1990. The primary role of the department is to provide data management support to healthcare, research, and training. We provide data management support to healthcare at our clinics and the laboratory in all our sites, including the regional centers of excellence. Currently, the regional centers of excellence are in Mbarara, Port Porto, Mbale, and Gulu. We provided data management support for now more than 20 years, beginning at the time at the height of the HIV/AIDS epidemic. So over time, we have built large databases, and this probably provides Jcrc with a unique opportunity to support scholars, learners, and for training. One of the areas of collaboration would be data management for HIV programs, data management for monitoring and evaluation of HIV programs, system development, and integrated systems. We also be able to provide training in research methodology and appreciation of the research environment. However, we think that prospective scholars, learners can, through our system, be able to propose some areas where we can both benefit, both Jcrc and other institutions can, in a collaborative manner, be able to suggest protocols, make proposals that can be implemented here. We have more than 10 collaborations going on now at Jcrc. One of them is the ACTG. Jcrc is a coordinating center. Again, we have built a lot of experience working with international partners. And so, anybody coming to work with us will get a wealth of experience on the top-notch current databases. We're talking about the SQL Server, we're talking about the integrated systems, we're talking about the lab information management system, we're talking about the integrated clinical enterprise application that we're running here. In research, scholars, learners will be able to appreciate the technology, the advent of technology into data management. Now you appreciate that when the HIV epidemic started, we're using paper-based systems. You will also be able to learn the transition between paper-based system to wholly electronic systems. We have the daily backups, and then we do weekly and then monthly backups to ensure that everything is safe and therefore can be accessed by anybody when we need. So basically, a paper-based system means that we just write details to do with the patient's episodes and history and all that in the file. At that point, we do not have a computerized system.
The research and grants department here at Jcrc, which I head, is one of the major pillars of this institution. As it comes from the name, it's the Joint Clinical Research Center. So it's really built onto on the foundation of research. We are doing mostly research on HIV and AIDS in the beginning, because that was the main reason why the institution was born. But also we touched on things like TB and some cancers that are very much related with HIV. As you know, TB and HIV kind of go so much hand in hand, especially here in the developing countries. So, but over time, as more treatment options have come on board, people are living longer with HIV now. It's no longer as a death sentence as it used to be, because now there is at least an option of treatment. If someone takes their treatment well, they have a chance to live a normal and productive life. But then we have seen an emergence of other health conditions that are now a problem to people living with HIV. These include cardiovascular diseases, includes some cancers and a host of other things, some of the uncommunicable diseases. So because of that, we've had also to focus on them as well, so that we don't focus on not just HIV/AIDS, but also we are now doing research in some of these other conditions. We have done research with the in collaboration with other research institutions within Uganda, but also outside of Uganda, on the African continent, but also we have a very good and long-standing partnership with the US researchers and also some in UK and other countries. And you may know that we are part of also of the network of the AIDS clinical trials group, which is the ACTG, which is funded by NIH in the US. So with that vast experience and background in research, we've also have now an opportunity to pass on some of the experiences that we've learned along the way in terms of research itself, the knowledge that we have acquired along the way, the experiences, and over time we've become a knowledge hub where a number of individuals as well as organizations come to Jcrc to learn from us, to benchmark, to get to know our story. How did we do it, and how may they also improve in what they are doing. So we've had an opportunity of hosting students as well, both from within the country, but also from other countries. And we take them through the different stages of research. We are doing research in human beings, and there's a lot of things that can go wrong on that. So we have independent bodies that come in to look at not only the science, of what you're going to be doing, but also the ethical aspect of it. Is it ethical? Have you taken care of their participants' autonomy? You're not exploiting them in any way. So students can learn that we have an opportunity, that we have a research and ethics committee here at the Joint Clinical Research Center, which reviews all the studies that we do here before they are approved. The ethics committee doesn't stop at only reviewing before the study starts, but they also go on to follow up the study, to monitor it. Is it being implemented according to the protocol, to what was approved? So there's those monitoring visits that ethics bodies do, or we call them inspection visits, to ensure that the research team is still compliant with what they set out to do and what they wrote in the protocol that was approved. Then what next after you've done all this? So there's a part, of course, we don't want to do research and then you shelve it. Whether it's you've got positive outcomes or negative outcomes, you don't want to just shelve it. Then it doesn't help anyone. So there's a part of disseminating that information. Okay, and that we do in terms of publications in the peer-reviewed journals. So how do you prepare a manuscript? Because you need to write a manuscript. So we have quite experienced researchers here, and also people that have been writing manuscript many times. So students can sit with these people and learn on how to write a good manuscript. And then which journals are you likely to target to be able to publish your information. But also we don't only publish in journals, we also do disseminate in maybe conferences, so students also get an opportunity to learn how do you make a presentation. Because many times in a conference you may have very limited time, at most you may have only 10 minutes to present your study. And then also, as we do studies, we do report as we go ahead. Because sometimes you get, you may not, you find that you, for one reason or another, either by commission or omission, you deviate from what you set out to do in the protocol. Okay? Some various reasons come for that. But how do you report that? Because every time you deviate from what you set out to do in the protocol, it has to be reported to the ethics body. Okay? And so students need to learn that. And then also, sometimes you get what I might say is maybe side effects or adverse events that may occur during the study. So how do you report them? What are the timelines? Where do you report them? So all that is very important. And the students can get an opportunity to learn all that, because if all that's not well done and well handled, then the research either becomes very dangerous to the participants themselves, or the information that is coming out actually is not a true representative of the nature of what you're trying to research on. So you have to be very meticulous in all these aspects.
I work with a team where we have representatives from different departments. That's the training committee for Joint Clinical Research Center. Basically, it advises the management. It is involved in developing training manuals, short courses, together with the other collaborators. But we also work with them to write research training grants. We basically manage the trainees when they come here, the different categories of trainees. Some are students, postgraduate, undergraduates, and some are employees from different health institutions, academic institutions that come here for placement. So they go to different departments. You must have seen the nursing department, the pharmacy, the ward, the research and grants,
pediatrics, radiology, tuberculosis clinic, and our laboratory. So they are attached to these different departments once they come here. But there is also an opportunity for the students to rotate. If they want, they pick interest in some aspects, one department, they can move and go and attend something they want in a department. For example, somebody may come in finance, but may pick interest in community engagement activities, may pick interest in what is happening in the counseling. So they are free to go there. So what happens is that students do apply. When they apply, they attach all their papers, including passports, photographs. When the application comes here, the committee looks at it. The different departments endorses. It goes to the executive director for approval, and then comes back to me and this office, and then we write the students the acceptance letter. So when the student is accepted, then he comes and pay. If he has to pay if he has to pay as an individual, but there are also students who come on an arrangement with an institution, for those institutions that will have the memorandums of understanding. So when the students come, or even before they come, they have to read the attachment terms of reference, where there are ethical issues and security issues when they come here, and sign them. And once they sign them, then we take them to the mother department, where they are going to be mentored and trained, and then they draw up a plan. What are they going to do per week, per day, per week, per month, and for the 2 months that they will be here. And usually when they apply, we respond in about 10 days. Everything should be done in about 10 days for a placement. So this is one of our training rooms where actually our students come. We have meetings with them, we brief them. It has a mounted LCD, and because of COVID you can see people spaced, and if these days when you have many, we divide the groups because of COVID. So we streamline them, we mentor them when they come, we take them through orientation. They are addressed by the executive director. They meet the committee, the different people from each department, and learn what each department offer. Then they go around all the departments. There is also an opportunity for students to be paired. You may come, for example, and you are studying cardiovascular disease in HIV, and another Ugandan or somebody from abroad has come to study the same. There's an opportunity to pair you so that there is peer mentorship. You mentor each other, you learn, and this to me has really worked well with the colleagues who come from outside Uganda. So they learn a lot along with the Ugandan that we pair with them. On request, the Joint Clinical Research Center organizes the most convenient accommodation available at a reasonable fee. We have some flats there, we have memorandum of understanding with them. So our students who come from far, within Uganda, because we handle local and international, so we arrange for them, but they pay for themselves. We are very conscious about security for the students. That's one thing that is emphasized for our audience. Please, are you looking for quality and professional internship experience? Are you yearning to work alongside experienced clinicians, specialized healthcare practitioners, experienced social scientists, experienced researchers, and trainers? And by the way, I'm a sociologist, but with the teaching profession background. That's a strength. So please travel to Uganda and learn from this Jcrc, which is one of the most prestigious HIV/AIDS treatment research and training center for other tropical diseases and in the region.